YouTube, welcome to Dr. Vibes, a learning point. In this video, we will study about volvulus. So first, what is volvulus? Volvulus is the rotation of a colon around its own axis and on its own mesocolon. So in this diagram, you can see that this curvilinear part which I have made is the colon. This yellow color part is the mesocolon, and this red color is the blood vessels. So now this colon has rotated on its own mesocolon and around its own axis, as you can see in the diagram that I have shown you. This is called as volvulus. Now there are three types of volvulus: sigmoid volvulus, circumvolvulus, and compound volvulus. What happens in compound volvulus? There is iliosigmoidal knotting. Most common is the sigmoid volvulus and the most rare is the cecal volvulus. Now let us study about the sigmoid volvulus in a bit details. One, it is more common in females rather than males. And one question that will arise to you: why is sigmoid volvulus occurring in one person and why it is not occurring in the other person? The answer to this is that there are some predisposing factors which lead to the formation of sigmoid volvulus. First, if there is a long and narrow mesentery, then it has more chances of rotating around itself. Second, if there is a redundant sigmoid. And third, if the sigmoid colon is loaded with some fecal matter. These three are the predisposing factors which can lead to the formation of volvulus: long and narrow mesentery, redundant sigmoid, and third is the sigmoid that is loaded with fecal matter. Now I have given you a clinical scenario that there is a 38-year-old male who is tall and thin-built, has a chronic constipation history for 2 days, and there is abdominal distension with obstipation, and since last 4 hours he is having colicky pain. So by giving this history, can you understand that this is a case of intestinal obstruction? Why? Because there are three characteristic features here. One is abdominal distension, second is obstipation, and third is abdominal pain. Now there are some examination findings, that is the pulse rate is 102 minutes per minute, BP is 100/60, and the patient is dehydrated. So the question arises that how will you manage this case? But before that, I will tell you the clinical features which can lead to or which are present in volvulus. One is abdominal distension as given in the question, then is obstipation, then is the abdominal pain which is colicky in nature, and fourth is vomiting. Now this vomiting is a feculent type of vomiting, which means that this is a very late feature of volvulus. And fifth point is that if perforation or strangulation is present, then there are some other features which will be seen, like cardboard rigidity, rebound tenderness. There will be gas under the diaphragm if you see in the chest x-ray, because we know that gas under the diaphragm signifies perforation. Obviously, there will be increased pulse rate, decreased BP, signs of shock, a toxic appearance, and a very severe pain that will be out of proportion. What investigations will you do in case of volvulus? You will do a direct x-ray of the abdomen. You will do a CCT if your patient is an adult, and if the patient is of pediatric age group, you do a USG, and you do contrast enema. Now, let me tell you three things. What is barium swallow, what is barium meal, and what is enema? So, if the patient has taken a barium compound and you are investigating the esophagus, then that is called as barium swallow. Barium meal, खाना कहाँ जाता है, मील कहाँ जाता है, स्टमक पे जाता है, so barium meal is stomach. And if barium meal follow through is the investigation of the intestine. And very easy is the enema, in which you will do the per rectal examination, that is barium enema. Okay. Now, what are the investigative findings that you will get? I told you that you will do the direct X-ray of the abdomen, you will do CCT, USG, but what will you get? So if you do a contrast enema, you get a bird beak appearance. And if you do a direct X-ray of the abdomen, you get a coffee bean appearance. These two are very important MCQs and very important points. So direct X-ray of the abdomen, coffee bean sign, and contrast enema will show you a bird beak appearance. Now comes how will you manage a case of volvulus. So first, as there are features of shock, you will do resuscitation with IV fluids, Ryle's tube for decompression, and per urethral catheterization for monitoring the urine output. This is the basic things that you do in everything. Then you do the standard radiological investigations to confirm the diagnosis. That is, you do the direct X-ray of the abdomen, you do the barium enema. Now, it is confirmed. Say it's confirmed that yes, it is sigmoid volvulus. So you have to decide if the patient is stable or if the patient is unstable. If the patient is stable, that means there is no signs of perforation or strangulation. That means no cardboard rigidity, no rebound tenderness, etc., etc. Or if the patient is unstable and then there are some features of strangulation of perfusion. So these are the two cases. Let us take up the first case. Let's say the patient is stable, that there are no features of perforation strangulation. You have to do a trial of sigmoidoscopic decompression. After doing this, if the volvulus is corrected and the patient improves, then you can discharge the patient. But if there are more chances of, recurrence, then the definite management is always surgery, that is sigmoidectomy. Now, let's consider a different case, that if the patient is unstable, that means he has the features of strangulation and perfusion, then you just open up the abdomen by exploratory laparotomy. You have to do sigmoidectomy, and that is followed by Hartmann's procedure. This is how you manage a case of volvulus. So this is all about volvulus in short. I have included what is volvulus, what are the types of volvulus, predisposing factors of volvulus, clinical features, what are the investigations, and how is the treatment.